Hello and welcome to a webinar on the challenges in interpreting results from PGT-A. I am Sarah Ramaya, Curriculum Designer at ASRM. Please join me in welcoming my colleagues Jessica Goldstein and today's moderator, Ms. Allie Boyd. Ms. Boyd is the genetic counselor at Stanford Fertility. She assists patients interested in pre-implantation genetic testing, carrier screening, and gamete donor services. Before we begin, please note, this webinar was developed by the American Society for Reproductive Medicine as an educational resource and service to its members and other reproductive professionals. While this webinar reflects the views of the panelists, it is not intended to be the only approved standard of practice or to dictate an exclusive course of treatment. Members should always use their best judgment in determining a course of action and be guided by the needs of the individual patient, available resources, and institutional and clinical practice limitations. All attendees will be muted except the presenters. Time at the end of the presentation will be reserved for questions. Please type a question in the question chat window at any time, and we will read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. I will now turn the presentation over to Ms. Boyd to introduce today's panelists and moderate the session.
Hi, everybody. This is Allie. Thank you for joining us. I can't wait to hear the presentations, and hopefully it generates a lot of interesting conversation. I know that there's a lot of questions in the field right now, and I just can't wait to hear what these three have to say. So the first presenter today is Dr. Catherine Rakowski. She's the director of the ART laboratory at Brigham and Women's Hospital in Boston, Massachusetts, and professor of obstetrics and gynecology at Harvard Medical School. She is president of the American Society for Reproductive Medicine, ASRM. Dr. Rakowski has authored more than 150 peer-reviewed papers on various aspects of mammalian egg and embryo physiology, has published numerous news releases and book chapters, and has co-edited 7 books. So with that, I'll hand it over to Dr. Rakowski.
Well, thank you so much, Allie, for that introduction. It's a real pleasure to be here today to discuss this really hot topic, interpreting results from PGT-A. So as is noted on the slide, the views expressed here do not necessarily reflect the views of ASRM. I am a full-time employee at Brigham and Women's Hospital in Boston. So the real question here is, why do we have these challenges? Why are we having this webinar today? And I think we can think about this in the context of challenges presented by the biology of the pre-implantation human embryo and challenges presented by the current PGA testing approaches. So with that in mind, what I would like to do over the next 10 minutes or so is, first of all, very briefly review with you the biology of the pre-implantation human embryo and discuss the 2 most frequent types of chromosome segregation error that occur in human embryos, and then outline implications of these errors for the accuracy of a PGT-A test. We'll then consider developments in PGT-A technologies. We'll discuss evidence for shortcomings with trophectoderm biopsy. We'll consider current findings and limitations with non-invasive PGT-A. And then finally, I want to circle back with you to the biology of the embryo and very briefly consider the potential compensatory mechanisms to correct chromosome segregation errors. So hopefully you're all familiar with the developmental timeline of the pre-implantation human embryo. As you can see, day 1, the fertilization, check 2 pronuclei, going right the way through to day 5. Hopefully we'll have a blastocyst, and on day 6.5, typically implantation. The green arrow here indicates the point at which genomic activation of the embryo occurs. And it's only if we get this activation that the embryo then is capable of proceeding from the 8-cell stage to the blastocyst stage. And in the absence of activation, it will remain arrested. And as we know, only around 40 to 50% of embryos in culture actually do form a blastocyst. The point in terms of this discussion is that mitotic errors during pre-implantation development typically are most likely to occur after the 3rd division. That is, after the embryo has reached the 8-cell stage. There are several different chromosome segregation errors that one can consider. What, for the ease of simplicity, I show here is just the 2 that are most prevalent, these being non-disjunction and anaphase lag. So with respect to non-disjunction, we have a situation where the chromatids do not separate from one another in a chromosome. And so the bivalent itself migrates to one end of the mitotic spindle or the other, in which case the daughter cell then will be trisomic for that particular chromosome, and the other daughter cell will be monosomic. In the context of anaphase lag, by contrast, the chromatids do indeed separate, but one of them fails to migrate to the end of the spindle, and so it gets lost during the division process. The other migrates appropriately. So in this case, then, we have a monosomic cell and we have a disomic cell. Now, the implications of these chromosomal errors are really quite considerable, because if you think about it, these errors lead to aneuploid cell lineages and to embryo mosaicism. And this issue of mosaicism really can pose problems whether we're talking about trophectoderm biopsy or whether we're talking about non-invasive PGT-A or niPGT-A, whether either of these procedures is performed. And obviously, with respect to trophectoderm biopsy, hopefully everybody knows we're literally biopsying a few cells from the trophectoderm of the blastocyst. Typically 3 to 5, maybe 6 cells that are removed. They're sent off for testing, and the hope there is that the karyotype of that group of cells is representative of the inner cell mass, and I'll be saying more about that in a second. In contrast with non-invasive PGT-A, we're culturing our embryos individually in microdrops, and at the end of the culture, we're removing the medium and assaying the spent culture media, which is typically collected on days 5 to 7. And we're hoping that there's going to be DNA in the culture media that is representative of the embryo, particularly the inner cell mass. So with respect to challenges to trophectoderm biopsy related to mosaicism, so sampling issues and errors depend on the distribution of the mosaicism. So in these cartoons, the blue cells indicate the cells are euploid, the red that they're aneuploid. And as you can see in both going from left to right, the first 2 images, if one biopsies 3 cells, as indicated by this bracket, you are biopsying cells that represent the inner cell mass. So you'll get the fidelity and you'll get a true result that shows you what the ploidy condition is of the ICM, which of course is the critical group of cells, because this is the group of cells from which the fetus develops. Likewise, with respect to the image on the right, the diploid-aneuploid mosaic, again, if one biopsies those 3 red cells and the inner cell mass is aneuploid, again, you get a representation of the test. However, situations become problematic when you have diploid mosaicism and you biopsy cells that do not represent the inner cell mass. The bottom left-hand one, you're probably okay, although it depends on the percentage of mosaicism in the cells you biopsy as compared with in the inner cell mass. But the 2 that really cause problems are the middle bottom one and the one on the right. So with respect to the middle bottom one, if one biopsies 3 euploid cells and the inner cell mass is aneuploid, you will end up with a false negative result. You will believe that the embryo by test is normal, the ICM is normal in its karyotype, whereas in actual fact, in this particular example, it's aneuploid. And conversely, the one on the right, if you biopsy 3 aneuploid cells and the ICM is euploid, you'll get a false positive result. And these have really caused problems, because the false positive results, you're deselecting embryos that otherwise could form babies. And as we all know, every embryo in a cohort is incredibly precious to a patient. So this possible deselection of embryos capable of producing healthy children is something of real concern. So the challenges to non-invasive PGT-A related to mosaicism, I think we can think of these challenges in terms of questions. So first of all, can cell-free DNA in spent culture media be reliably amplified and sequenced? Where does the DNA in the spent culture media originate? Is it from apoptotic cells? Is it from the trophectoderm cells? Or from the ICM? One hopes, as I mentioned earlier, that it will at least be in part from the ICM, since this is the group of cells that is of particular interest to us. Can we get ploidy information on the ICM from the cell-free DNA? In other words, what is the concordance between the 2? How accurate does the cell-free DNA karyotype represent the ICM karyotype? And then what about fragments, fragmented DNA in this spent culture media? And how would these fragments possibly interfere with the read? And then finally and critically, for any clinical tests, we need to know what the performance characteristics are of the niPGT-A test. So with respect to non-invasive chromosome testing, the first baby that was conceived after selection by this technique was born in March the 14th, 2016. And as you can see, the authors have given us the performance characteristics of their test at the time. And you can see the sensitivity was 88.2%, the specificity was 84%, the false negative rate 11.8%, and the false positive rate 16%. And the authors went on to consider the potential origin of the false negatives and false positives. And as you can see, they surmised that the false negatives presumably can come from contamination from maternal cumulus cells. However carefully you strip the oocyte, the cumulus cells from the egg, there is a possibility that a cell or parts of a cell may remain in the zona pellucida. And then with respect to the origin of the false positives, as I've indicated, this undoubtedly is due to mosaicism. So since this paper in 2016, there have been many other papers published on non-invasive PGT-A, and I show you just 6 of these here. The goal here being all the time to try to understand what the relationship is between non-invasive PGT-A and trophectoderm biopsy. Do they produce similar results? Are there different results? And if they're different, how greatly are they different? And which might be the best approach? So the paper on the bottom left was a paper that we published in 2019, where we used donated embryos. And we were able to report the performance characteristics for that study. But this data here is 81 embryos from a very recent study by Rubio et al. From the iGenomics group. And what they did was they took 81 embryos from this very large cohort of embryos, 1,301 embryos that they actually had in the study. These were donated embryos, obviously, and what they did was they compared the cell-free DNA with the trophectoderm biopsy results, and also with the inner cell mass. They were able to dissect the embryo into the 2 compartments, the trophectoderm and also the inner cell mass. And as you can see here, SBM standing for the spent blastocyst media, so the cell-free DNA media, versus the inner cell mass. As I've indicated in the red circle here, the false positive rate was 6.2% and the false negative rate was 9.4% in this particular analysis. So certainly these values aren't 0, as you can see, but they're both under 10%. Not bad, but certainly still room for improvement. So this is our data, which I thought I was going to show you before the previous slide. So this is our data from the study that we published in 2019. And as you can see here, what we did here, we compared the performance of the cell-free DNA test with the whole embryo. We didn't pass it into the trophectoderm and the inner cell mass. And what I think is of importance here, the sensitivity, i.e. the true positives, were 100% in our study, and the specificity, i.e. the true negatives, were 80%. So still not perfect by any means with respect to the true negatives, but at least the true positives in that study were 100%. We set the threshold, the sequencing threshold, at 60%, and we might want to discuss that more during the Q&A, because it's very important to set the threshold for mosaicism when you're using bioinformatics to determine the final results of these sorts of analyses. So with respect to comments regarding the cell-free DNA or the niGT-A assay, there's no doubt this approach has potential as a non-invasive and potentially safer and more effective test for PGT-A than trophectoderm biopsy. However, as I think I've demonstrated to you, the test is not perfect and so certainly requires further refinements. I think it's important to note that in fact no PGT-A test can guarantee a healthy offspring ever. It's very rare that I say never in science, but this is a situation where there are so many unknowns with the human embryo and there's so much heterogeneity among embryos, it's very unlikely that we'll have full understanding of the development of an embryo to the point where we'll be able to develop a test where we can guarantee a healthy offspring given a particular result. Importantly, several variables need to be considered for development of a risk scoring system for mosaicism, such as, for example, the percent mosaicism, as I alluded to a second ago, which chromosomes are involved, whether it's monosomy or trisomy that's in question, and whether a complete or segmental mosaicism is involved. So as I think everybody listening is perhaps aware, there have been reports of mosaic embryos being transferred that have given rise to healthy offspring. And this slide shows you the original paper that was published by Greco in 2015, reporting 6 out of 18 embryos that were known mosaic by test that gave rise to live births. And this really raised a lot of interest in the field, because up to that point, we were pretty much excluding transfer of any mosaic embryo. And by the way, all these patients, these 18 patients, they had no normal embryos by test to transfer, and this was the last resort for them to use these mosaic embryos. So clearly the need for patient counseling is highlighted by the fact that there are now numerous reports of embryos tested as mosaic that resulted in healthy offspring. And I show you here just one other study that was published 2 years later in 2017 by the Spinella et al. And as you can see here, you can see that the pregnancies to term for the euploid transfers was 46.4%, and for the mosaic was 30%. So clearly lower for mosaic, but nevertheless, nearly 1 in 3 embryos that were transferred that were reported as mosaic actually gave rise to a healthy live-term baby. And then in the next slide, we see the comparison of the pregnancy to term rates when the authors split the embryos into embryos of less than 50% mosaicism by report to those of 50% or more. And you can see here there's really a dramatic difference. So in the embryos that exhibited less than 50% mosaicism, there was a pregnancy to term rate of 40.9%, as compared with only 15% in embryos of greater than or equal to 50%. And you can see that this was a statistically significant result. Having said only there, 15% for a patient who is absolutely desperate to have a baby and who has no normal euploid embryos to transfer, this 15% is a huge number for them. So how has all this come about? How do embryos that are mosaic actually give rise to healthy babies? Well, there are various models that have been proposed for self-correction of the embryos, and these include the clonal depletion model, where apoptosis or reduced division of aneuploidy cells occurs, so ultimately these abnormal cells actually get culled out during development. And then one of the other popular models is the trisomic monosomic rescue model, where aneuploid cells give rise to diploid cells through mitotic loss or gain, depending upon whether they were triploid or monosomic. So these are two models of actually several that have been proposed for this correction. But clearly embryos do undergo correction if one believes the testing results that we're actually obtaining. Now it's important, having said all that there is this report that just came out. It came out in March of 2020. And this report actually shows that an embryo that was mosaic by report led to the birth of a baby that also was mosaic for the same chromosome. So in this particular instance, as is indicated here, there was transfer in an embryo that was reported as 35% mosaic for chromosome 2. The embryo revealed a mosaic trisomy for 22. A healthy girl was born at 37 weeks. And they did the work and they showed that the peripheral blood of the baby actually showed 2% mosaicism monosomy. So we can't always just assume and tell patients that a mosaic embryo, if it is going to give rise to a healthy baby, is going to be an embryo that's fully euploid. There is the possibility that it could be a mosaic. So just in closing remarks then, I think it's very clear that there are challenges imposed by the biology of the embryos. There are errors in chromosome segregation, which occur, and some of which are corrected as development proceeds. And we don't know, looking at an embryo, which embryos are going to undergo correction and which aren't at the moment when we perform embryo transfer. Because neither trophectoderm biopsy or non-invasive PGT-A are perfect, patient counseling on the nuances and interpretation of the results is required. And current knowledge on the implications of transferring an embryo with a specific mosaic profile is really critical. Obviously, I'm a scientist. More research is definitely needed in this area. This is still very much a moving target with respect to the development of the technologies and the interpretation of the results. And so the role of genetic counselors in informing patients prior to their transfer and even perhaps after their transfer is really critical. So thank you so much. I'll be happy to answer questions in the Q&A at the end of this, the third presentation in this webinar.
Thank you for that, Dr. Rakowski. That was a really great kind of background, and I think it'll really help us moving forward with the other two talks. So now we are going to hear from Dr. Alyssa Snyder. Dr. Snyder is Director of Genetic Counseling at iGenomics. She received her PhD in genetics from Stanford University and her master's degree in genetic counseling from California State University, Stanislaus. Dr. Snyder was the first genetic counselor at iGenomics and is responsible for establishing the current genetic counseling department. She is a past chair of the ASRM Genetic Counseling Special Interest Group, now the Genetic Counseling Professional Group, and also a past chair of the IVF ART Special Interest Group of the National Society of Genetic Counseling. Alyssa?
Thanks, Allie, and thanks, Dr. Rakowski, for your presentation. And hello to all of our participants today. I'm so excited and honored to present to you on the topic of non-invasive PGT-A, or as I will call it throughout my presentation, embryonic cell-free DNA analysis. And I'd like to disclose that I'm a full-time employee of iGenomics. So I was asked as a laboratory-based genetic counselor to present about non-invasive PGT-A. And as a genetic counselor, I think a lot about informed consent and test utilization. And test utilization really gets at this difference between screening and diagnostic testing. So I'd like to start by mapping out the differences between these two. And as we go, we can ask ourselves, where does PGT-A fit in, either from a trophectoderm biopsy or from a cell-free DNA analysis? Screening tests really target low-risk or healthy individuals, whereas diagnostic testing targets high-risk or symptomatic individuals. So automatically, we can begin to see that PGT-A falls somewhere in between, because PGT-A is typically offered to individuals who are themselves healthy but are struggling with infertility, and they may be of advanced maternal age and have a higher risk to have embryos with aneuploidy. Screening tests are typically low cost with minimal invasiveness, and diagnostic testing is usually invasive and costly. And traditional PGT-A would probably fall in the category of diagnostic testing in that regard, because it involves an embryo biopsy and is invasive, whereas non-invasive PGT-A testing may still be costly, but it has minimal invasiveness, so it would be more on the side of a screening test. Screening tests will prioritize sensitivity. The intent is to identify as many at-risk individuals as possible, whereas diagnostic testing will target specificity. The intent is to exclude as many healthy individuals as possible. And you can see that PGT-A is pretty solidly in between these two categories. We really want to minimize the chance of false positives, because an embryo with a false positive result could be an embryo that would be excluded unnecessarily, and that could ultimately reduce the chance that that patient has a successful pregnancy. Similarly, we want to reduce the chance for a false negative result, because a false negative result could be an embryo that is transferred but then result in either implantation failure or miscarriage or the birth of a baby with a chromosome abnormality. And the utility of a screening test is typically to catch as many individuals as possible and then to escalate those individuals to diagnostic testing, whereas diagnostic testing, the utility is to enable decision making, because those results are greater than 99% accurate and are considered diagnostic. For screening tests, the accuracy or the predictive values is based off of that follow-up diagnostic testing that is used to validate the results of the screening test. So that begins to be a bit of a problem with PGT-A, because while PGT-A is not technically a diagnostic tool, there really isn't any other diagnostic tool that's available at the time of the pre-implantation embryo to verify the results of PGT-A. And so we are using PGT-A in most cases as a tool to make decisions about embryo transfer or disposition. So new technologies come with the promise of improved healthcare, and for our IVF patients, this means an increased chance of having a healthy baby. However, we must counsel our patients cautiously, acknowledging the caveats and the limitations of new technology, and we have to ask, how is the test validated? What performance measures are used, like accuracy, sensitivity, specificity, PPVs and NPVs? How are these performance measures determined? And unfortunately, with PGT-A, there's no diagnostic test that can be used to validate the results prior to embryo transfer. Diagnostic tests like CVS and amniocentesis are only available once a pregnancy has already been achieved. And furthermore, clinical outcome is not a perfect gold standard because implantation would not confirm a euploid result any more than failed implantation would confirm an aneuploid result. Therefore, we really lack the PPV and the NPV, even for traditional PGT-A, and yet now we're using PGT-A as the gold standard to validate cell-free DNA analysis. And what we really need to confidently counsel patients and practice evidence-based medicine is clinical outcomes through multiple research studies and RCTs. So to my knowledge, there are only a few different niPGT-A tests currently on the market. And the one that I'm most familiar with is the one called Embrace. I was asked, along with an international team of other genetic counselors and experts, to travel to headquarters in Spain to help transition the non-invasive technology from the research sector to a genetic test that can be used for patients in a clinical setting. And so the test that I'm describing is the one that I have the most experience with, although it was recently just launched, and we are still in the process of validating clinics before allowing any clinical samples to be sent to us. And our third speaker, Erin Barone, will be speaking about some cases where patients had non-invasive PGT-A testing performed. And I wanted to clarify that that analysis was performed by a different group. And so while we recently just launched the test, Embrace was validated based off of concordance with PGT-A of trophectoderm biopsies, inner cell masses, and with some pilot clinical outcome data. The protocol really is non-invasive. It doesn't require any assisted hatching or any freeze-thaw cycles. And one of the unique things about Embrace is that it is intended to be used as a prioritization tool rather than a selection or exclusion tool like traditional PGT-A. And the prioritization is based on concordance with PGT-A. In other words, for that embryo with a cell-free DNA result, how likely would that embryo be to have a euploid result if it were to undergo embryo biopsy? So with embryonic cell-free DNA screening, there's the exciting possibility that the analysis could actually be more representative of the embryo as a whole because it utilizes DNA that's in the culture media surrounding the entire embryo compared to traditional PGT-A that relies on a representative sample of just a few cells from the trophectoderm. While this is an exciting possibility, it's important to note that it is not yet proven. What we do know is that we can get similar quantities of DNA from euploid and aneuploid embryos. And so if you go with a hypothesis that cell-free DNA originates from apoptosis, that apoptosis would be part of a normal development process rather than from abnormal embryos that are trying to spit out their aneuploid cells. Furthermore, we can hypothesize that cell-free DNA does originate from both the trophectoderm and the inner cell mass because we can see some similar concordance rates between the inner cell mass and the cell-free DNA analysis, about 86%. And with the trophectoderm and the cell-free DNA, we see about 22%. And this is the concordance between the cell-free DNA and the inner cell mass is slightly reduced compared to this, but still in a comparable range, similar to what we see between the concordance between the trophectoderm and the inner cell mass. And as Dr. Rakowski mentioned in her slides, we do see false positives and we do see false negatives. False positives can result from mosaicism or even amplification bias, since cell-free DNA does require additional rounds of amplification due to the low quantity of DNA that can be obtained from the blastocyst media. There are also false positives. First, I want to say that the false positives, that term is itself slightly inaccurate because there could be real aneuploidy in the trophectoderm that could affect implantation or placentation. And just because the inner cell mass is euploid does not guarantee a successful pregnancy. We also see false negatives that can result because the test is very sensitive to cumulus cell contamination or even embryologist contamination. So this chart summarizes the results of a multi-center prospective study, including 8 different centers where the concordance rates between cell-free DNA analysis and trophectoderm biopsies were examined. And you can see that the concordance rates varies quite a bit center to center, with a concordance rate as high as 86% for center number 4 and as low as 72% for center number 7. And we think that a lot of the variability between the concordance rates is due to the way that the clinics follow this strict protocol to control confounders of contamination, either cumulus cell contamination or even embryologist contamination. So given that the concordance with PGT-A is not going to be 100%, it is important to consider the test utilization. So with test utilization, it asks the question, what options do patients have for their embryos with aneuploid findings? So if you understand that the results of cell-free DNA may not be perfect, and to be honest, we really don't know, we're using PGT-A as the gold standard, but we really don't know which test is more accurate for the embryo at this point. As I mentioned before, we need clinical outcome studies. So if you go with the point that these results are going to be imperfect, then we have to carefully think about how are we going to use the results. Will we allow patients to transfer their embryos with aneuploid findings? This would be using the test as a prioritization tool, or would you be using the test to select embryos that are euploid and discard embryos that are aneuploid? Could embryos be frozen and stored until we know more? Could embryos be retested through trophectoderm biopsy and traditional PGT-A? Or perhaps might the clinic be willing to transfer those embryos out to another clinic who might be more amenable to transferring those aneuploid embryos? And then the next question is, what flexibility does the clinic policy have given a patient's special circumstances? Perhaps patients should be treated differently if this is their very first IVF cycle and they have the option to do another or perhaps a third round of IVF, compared to the older patient who's already done multiple rounds of IVF and says, I'm done, this is my last shot. And whatever your clinic decides, it's crucial that patients be informed about their options prior to testing. So I'd like to illustrate these questions by providing a few potential results. This first example would be full trisomy of chromosome 6. I think most people, if they saw this result on traditional PGT-A, would exclude this embryo for transfer, would not give a patient the option to do so. But what if I told you that this was the result of a cell-free DNA analysis and that the concordance with PGT-A was only 85%? Would that change your opinion? To go even further, here's an example of isolated segmental duplication of chromosome 9. Typically, if seen on PGT-A, this embryo would not be considered for transfer. But what if I told you that the predictive value of this result on cell-free DNA analysis was only 25%, and the chance for this embryo to have a euploid PGT-A result after embryo biopsy was actually quite high? And we can further illustrate this point by looking at a set of hypothetical results. So here we see 4 different embryos. Embryo number 1 on the left and embryo number 7 on the right are both euploid embryos, and they are given a high priority for transfer, priority number 1. And then embryo number 3 and embryo number 5 are embryos with aneuploid findings. Embryo number 3 would be similar to the first example that I showed with full trisomy of chromosome 6. And embryo number 5 would be like the second example where I showed you with the segmental duplication. And you can see that for embryo number 3 with a single trisomy, it's given a very low euploidy score. And the euploidy score is the chance that if this embryo were to undergo biopsy and then have traditional PGT-A performed, how likely would that embryo be to have a euploid result? And so you can see it's not 0, even for a full trisomy of that chromosome. In contrast, if you look at embryo number 5 with a segmental duplication, the euploidy score is quite high, just slightly reduced compared to euploid embryos. And this is because we found that the concordance with segmental aneuploidies with the PGT-A results is actually fairly low. And so this embryo with the segmental duplication has a high chance that it would be euploid if tested through biopsy and PGT-A results. So the question is, would the provider feel comfortable transferring embryo number 5? And what about embryo number 3? Of note, EMBRACE does have the option of masking specific aneuploid findings and only providing the euploid score. And once again, you'll notice that the guidance that is provided here for the priority list is based off of concordance with PGT-A as a reference point, which is sort of a flawed way of looking at it, but it's all we have right now. What we need to really counsel patients in an evidence-based method approach is clinical outcome data. Because the technology is new, clinical outcome data is simply limited. So here's an example of some clinical outcome data that we currently have. You'll see that there are 29 embryos that were included in this study. And of the embryos that were transferred, all of them have euploid trophectoderm results. We're not prepared yet to transfer embryos with aneuploid results for the most part. So in the first column, you see euploid embryos from trophectoderm and cell-free DNA analysis. And in the second column, you see embryos that were transferred with euploid trophectoderm results, but aneuploid cell-free DNA analysis. And the results of this pilot study are encouraging. If you look at the ongoing implantation rate at the bottom, you see that there's a 53% ongoing implantation rate for the embryos that were euploid for both analysis versus the 17% ongoing implantation rates for embryos that were aneuploid for cell-free DNA analysis. To second that, if you look at the clinical miscarriage rate, it is elevated for embryos that have an aneuploid cell-free DNA analysis result. What's lacking here is embryos that are aneuploid for trophectoderm, but euploid for cell-free DNA analysis. And that's what we need next with randomized control trials. Next slide. So I'm not going to go into the details of this study other than to just say that we need multiple research studies and RCTs involving control groups and treatment groups where they receive cell-free DNA analysis without comparing it to PGT-A. And that's going to be version 2 of cell-free DNA analysis, is where we validate it based off of clinical outcome data. However imperfect clinical outcome data itself may be. So I'd like to conclude by just reminding the audience that all genetic testing is optional and that only an informed patient can consent to a genetic test. And we should be discussing with patients why they should elect chromosome screening, what are the benefits, similarly, what are the risks and limitations of a test, and to ask ourselves, does the patient have the choice of the 2 different methods? This is going to depend on your clinic policy. And if they do have the choice, how are we mapping out the pros and the cons of the 2 different analysis for the patient? So in summary, PGT-A is not a diagnostic test, but is often used as such for determining the fate of embryos, either to transfer them or to discard them. And we should be considering carefully test utility. How will the test results be used? Can the test results be used to prioritize embryos, or will we still be using the test to select or exclude embryos based off of the findings? And patients must be informed about the clinic policy prior to undergoing testing. As a genetic counselor, I speak to a lot of patients that didn't understand their clinic's policies and really regret having done the test because it wasn't what they were expecting. And we need to ask, how will patients be counseled? Will they have access to pre-test counseling, which can enable informed consent? And will they have access to post-test counseling about the results, which can help guide decisions about embryo transfer? Thank you very much, and I'll take questions at the end.
Thank you, Alyssa, for that. That was really great. And I think moving into some real-world examples will be helpful to see how this can be a challenge in practice. So Erin Barone is going to guide us through some of that. So she graduated in 2019 with a master's degree in genetic counseling from Long Island University Post. She began her training to become a genetic counselor while working as a genetic counseling assistant and completing her undergraduate degree. She is the first and currently the only genetic counselor at New Hope Fertility Center in New York City, where she provides genetic counseling to patients about carrier screening, non-invasive prenatal PGT-A and PGT-M results. Erin?
Thank you, Ali, and thank you, Dr. Rakowski and Alyssa, for your great talks. I'm kind of going to switch gears here. Before I do, I just want to note that, again, the views expressed here do not necessarily reflect the views of ASRM, and I am a full-time employee of New Hope Fertility Center. So today, I really want to outline 3 case examples where we did see discordant trophectoderm biopsy PGT-A results along with non-invasive PGT-A results. I'll be talking about the follow-up on each case for our clinic and touching on and really highlighting, I guess I should say, the genetic counseling considerations when interpreting these discordant results in the clinic with the patient and their clinical team. So I want to begin our first case with patient YP. She is a 40-year-old female. Her initial non-invasive PGT-A testing was done in September of 2019 in-house at New Hope. She sent 5 samples for testing, and all 5 samples came back aneuploid. She was interested in a male embryo, and so 3 of the 5 samples she had tested were male embryos. She discussed these results further with her doctor, and her doctor suggested that she retest these embryos via the trophectoderm biopsy, particularly the 3 male embryos, as that was the gender that she was interested in at the moment. So her 3 male embryos were thawed and had a biopsy taken, and those biopsy samples were sent out for testing. So as you can see, the top bullet listing her niPGT-A results from September. Her first sample, as you can see, was listed as, or the test reported back as a monosomy 15. Her second sample had some various segmental deletions and duplications. The percentages in parentheses indicate levels of mosaicism for the subsequent abnormalities. And her third sample had 2 full monosomies as well as a 2 segmental deletions. Furthermore, with the second bullet, her trophectoderm biopsy results, which were performed the following month, showed that her first sample did come back exactly, as the non-invasive test identified with the monosomy 15. However, I want to touch on her second and third sample that did identify the trisomy 21 that we did identify non-invasively, however, at 70% abnormality. And her third sample did confirm the 2 full monosomies that were identified in her non-invasive samples. Again, that just highlights what exactly the abnormalities were that we picked up through non-invasive testing, and then which ones were additionally picked up through the trophectoderm biopsy. So some follow-up for this patient is a bit trickier than the average patient. She is an international patient from China, and we did inform, we have a clinical team that corresponds with our international patients in China, and I did speak with them, and as did her doctors. They received notification of both sets of results and were attempting to inform the patient. However, the patient has not been back to our center since the biopsy samples were sent out for testing, and she has subsequently not made any contact with us since her September 2019 decision to rebiopsy those initial embryo samples. So if she, we do like to say if she does return to our center, we would strongly recommend genetic counseling for her and her partner to review both sets of results, given that she had no follow-up with the second round of results. If they were to proceed with an abnormal transfer for XY purposes and did not want to go through another cycle to hopefully test further embryos with a euploid male, the embryos with the monosomies would be recommended for transfer over the embryo with trisomy 21 for obvious reasons. Monosomy embryos, other than Turner syndrome 45X, are typically not viable. Our second case that I wanted to touch on is patient YX, who is a 34-year-old female. She also had her initial non-invasive PGT-A done in September of 2019. She also had 5 samples sent out for testing. 1 female embryo came back euploid, and 4 mosaic embryos were the results of that testing, 1 female and 3 male. Given the patient's age and the expectation for more euploid embryos possibly than what the non-invasive PGT-A was showing, her doctor suggested that she retest these embryos by biopsy. So her 4 mosaic embryos were again thawed, had biopsy samples collected from the trophectoderm, and those samples were sent out for testing. As you can see, again, the top bullet are the results for her 4 mosaic embryos from the non-invasive testing, with abnormalities highlighted in both categories that were picked up. In her first sample, as you can see, a segmental deletion in 50% of the cells that following with her second 3 samples, further segmental aneuploidies, all mosaic. This case is rather an interesting one in that when we received back her trophectoderm biopsy results, sample 1 was reported back with different aneuploidies than what the non-invasive test even picked up. And her second set of samples, sample 2, 3, and 4, were reported back as all euploid. Again, this patient is also an international patient from China, similar story, who has dropped contact with us. We have not been able to get in touch with her since receiving the second batch of results. Her clinical team responsible for corresponding with the Chinese patients did receive notification of both sets of results and attempted to contact her. She has not reached out or returned to center since October of that year. Similarly to our previous case, genetic counseling is strongly recommended should she present back to our center so that we can review the second round of test results with her, as well as the touch base back on the first set of results. So some follow-up with the results of this patient. We did see some discordance with all 4 of the mosaic samples that she sent out. Particularly, we saw 3 of the 4 mosaic embryos are now being reported as euploid through trophectoderm biopsy testing. We know this, the biopsy site or the cell samples may not have included abnormal cells, which we know could be a limitation of trophectoderm biopsy, and that certain cells may not be sampled, which could impact the reporting of the results. The trophectoderm, for example, may be euploid. The inner cell mass may be aneuploid. The aneuploid cells may also be in the trophectoderm or the inner cell mass, which the biopsy may have missed. For her first sample that on trophectoderm biopsy reported back completely different aneuploidies, I've had many internal discussions with the lab director and some of the physicians following her case, and we cannot seem to come to a conclusion for why the sample number 1 produced a completely different aneuploidies. We tend to discuss niPGT-A in that it should represent the embryo as a whole because we're not directly sampling a single site on the trophectoderm as we are with the biopsy. So it's assumed that the non-invasive PGT-A would have additionally picked up the aneuploidies identified via biopsy, should they truly have been there. So our third case that I would like to touch on today is patient MC. She's also a 34-year-old female. She and her partner had expanded carrier screening, which identified them to both be carriers of this autosomal recessive condition, combined oxidative phosphorylation deficiency type 3. She had 2 samples that were sent out for PGT-M and PGT-A through biopsy in September of 2019, and both came back aneuploid, therefore, per our center, not highly recommended for transfer. Following those results, she had another cycle and retrieval, and she created another embryo that she wished to send out for testing. However, this embryo was initially sent out for non-invasive PGT-A rather than the trophectoderm biopsy PGT-M, PGT-A, as her previous 2 embryos were. So this embryo had to be rebiopsied for the PGT-M and A and subsequently sent out for testing, as non-invasive PGT-A cannot detect the single gene disorders. Her plan was for trophectoderm biopsy PGT-M with PGT-A, traditional biopsy. So the first bullet does have her non-invasive results for this embryo just for aneuploidy screening. And as you can see, a segmental deletion was found in 50% of cells, so the embryo was reported as mosaic. That subsequent biopsy that was collected for this embryo and was sent out for trophectoderm screening for PGT-M and A did show that this embryo came back euploid per that testing, and thankfully was only a carrier for the autosomal recessive condition that both parents were carriers for themselves. So this this became a very sensitive case for the patient. So all communication was between the patient and her doctor at this point, and they discussed the trophectoderm biopsy results, the patient's partner and her physician. They ultimately elected to proceed with that single embryo transfer of this euploid carrier embryo based on those trophectoderm biopsy results. Thankfully and fortunately for her, her pregnancy, she did achieve pregnancy with that transfer. And at 9 weeks, she graduated from our center and was to be followed by her OBGYN for the remainder of the pregnancy. We did hear back, or her physician did hear back from her OBGYN that her first trimester screening showed an increased risk for trisomy 13. And we do know that first trimester screening, as it being a screening test, has about a 5% false positive rate. The patient did follow up with diagnostic testing through amniocentesis in this situation to confirm or rule out that first trimester screen result. And the diagnostic testing confirmed normal fetal chromosomes and additionally confirmed the carrier status, which was previously reported on PGT-A. The patient felt much more reassured about her pregnancy after this normal amniocentesis result, and her estimated due date was this month. Our clinic will follow up with the patient in the next couple of months for the outcome of her pregnancy, birth weight, all of that information. So some genetic counseling considerations that I do want to touch on from these real-world case examples. In some instances, confirming the niPGT-A result via the trophectoderm biopsy may be helpful, but we have to keep in mind that some discordance is a possibility and can present with challenges in result interpretation and subsequent genetic counseling for the patient. So additional mosaicism detected by the niPGT-A, but not in trophectoderm biopsy, does have the potential to be artifact or a noisy signal from the testing, and cells that were not included in the PGT-M biopsy, such as DNA fragments from the inner cell mass, will not be tested for, which we hope and anticipate will be screened for through the non-invasive media collection. Additionally, abnormal niPGT-A results that are supported by subsequent trophectoderm biopsy may help the patient understand likelihood outcomes of embryos if transferred. The patient may feel some sense of confirmation that there's, so to speak, physical evidence in the embryo of an aneuploidy that was detected in both the non-invasive PGT-A and the trophectoderm biopsy PGT-A, which for some people, depending on what, the type of person, may provide a more tangible result for the patient to comprehend from them sort of picturing the media collection versus the physical cells that were biopsied from the embryo. Additionally, abnormal non-invasive PGT-A results that are not supported by trophectoderm biopsy may cause confusion for a patient in which result he or she should believe. And I kind of like to refer back to the patient that had the mosaic embryos on non-invasive screening, which came back euploid after trophectoderm biopsy. We and I'm sure the patients more so than us want to see those euploid embryos. That's the number one goal. Those are the first priority for transfer. So it may cause some confusion or apprehension, given that some aneuploidy, albeit mosaic, was identified previously, and now they are seeing a euploid result. As everyone has mentioned tonight already, and I want to echo that, it's important that the patients receive genetic counseling about, in this situation, both sets of these results to discuss the limitations of any pre-implantation genetic testing, whether it's through biopsy or the non-invasive method. The trophectoderm biopsy may not have included all the abnormal cells, as I previously mentioned, which were giving off the aneuploid results in the non-invasive PGT-A method. We know that no PGT-A is 100% accurate, and misdiagnosis can occur, with mosaicism being one of the causes for that. So we recommend to follow up during the pregnancy for that patient with diagnostic testing through amniocentesis, which is preferred for direct sampling of fetal DNA after any PGT transferred embryo to confirm the result. This includes, we have this discussion with patients even following euploid transfers, in that kind of to piggyback again, no PGT is 100% accurate. So, and to echo, no, pregnancy does not confirm a euploid embryo or a euploid pregnancy. Our patients who transfer euploid embryos do not necessarily jump at the idea of amniocentesis for obvious reasons. They're comfortable with the non-invasive screening that they've had, whereas some of our patients who transfer abnormal or mosaic, I should say, may. So lastly, genetic counseling is very important for the patient or couple to understand their results and limitations in their next steps. No pre-implantation screening method can guarantee a chromosomally normal offspring. We can transfer an abnormal or mosaic embryo and wait and see if pregnancy is achieved, but really stress and recommend the recommendation for diagnostic testing during a pregnancy. And if diagnostic testing does confirm an aneuploidy, then the patient must face the difficult decision to either continue with the pregnancy and maybe prepare for the birth of a child who may or may not have extra needs, or they can choose to stop the pregnancy, both of which do come with their own psychological and emotional impacts or stressors. We do know that, as previously mentioned, that these mosaic embryos can undergo self-correction. However, this is not a guaranteed process that we can say to patients looking at a result on paper that this will take place or this will not take place. Does the patient want to take on uncertainty when transferring an embryo that has discordant results between the two types of testing? As previously stated by the other speakers, some of these embryos may be these patients' last chances for a biological child, and maybe their first child. We do know that the miscarriage rate is higher for embryos that are mosaic than if an embryo is reported as euploid on testing. So that's another sort of deciding factor that a patient needs to understand and consider. From that, will they have any excess anxiety during their pregnancy? We want them to enjoy being pregnant and all the happy and beautiful things that come along with it, not have excess stress or worry leading up to waiting to have the amniocentesis for further confirmation. And with that, will they elect or decline diagnostic testing? The benefits of the results that they get back and the information versus the risks of an invasive test. So it's important to counsel patients that, should an ongoing pregnancy result from a mosaic transfer or an embryo that had discordant results, further testing during that pregnancy is still strongly recommended. The outcomes predicted solely based on the successful implantation and the subsequent ongoing pregnancy, the outcomes cannot be predicted solely based on those things. Thank you for listening.
Thank you very much. We will now open up the floor to questions for our panelists. Ms. Boyd will moderate this session.
Thank you, everyone, for those presentations. It was really, really great. There's just one question right now, but I actually have a couple of questions. So if we don't get more, maybe we'll go through those. So maybe Dr. Rakowski can answer this first one. Do you foresee that in the future embryo analysis will include a combination of trophectoderm and spent media results?
That's a really, really good question. I actually think that embryo assessment will include even more than that. I don't know whether it will include both of the genetic tests that we've been discussing tonight, but I really believe that other things are very important to making an embryo viable and competent to implant, other than just the chromosomal competency of the embryo. So one can envision, for example, and we all know about the time-lapse imaging, there's some information that can be gleaned from that, but there's also the metabolic, not metabolomic, but metabolic approaches that are being developed. And I'm involved actually with a group at Harvard University where we're really trying to develop a metabolic assay that will help inform the viability of the embryo above and beyond the ploidy of the embryo. So I think, as I've said so many times, I really believe it's a multi-pronged approach. I don't believe that any one is going to be the only standard by which we assess embryos. As I mentioned when I was giving my short presentation, the heterogeneity in embryos is so extraordinary. There is so much that we simply do not understand about the development of the embryo and are likely never really to understand because of the complexity of it, that I think the more approaches that we take to try to develop an algorithm that will increase the sensitivity of the assessment test, I think the better off we're going to be.
I can add to that if you don't mind. with perhaps a slightly narrower scope. Dr. Rakowski has her mind on a lot of different things. And I can see that in the near future, patients that get a euploid result from cell-free DNA analysis might feel comfortable transferring that embryo, but might be really unsure what to do with an aneuploid result. And I can foresee that for some clinics, for some patients that are nervous about what to do with that aneuploid result, that they might want to then biopsy the aneuploid embryos and undergo traditional PGT-A testing. I don't think that would happen long term. I think once we know more about how cell-free DNA analysis performs, that wouldn't be necessary and it would be one test or the other.
Can niPGT-A truly be considered non-invasive if it requires multiple manipulations, washes, and potentially delaying vitrification of an expanded 5-day blastocyst? Dr. Rakowski, would you like to take a first stab at that one?
I'm not quite sure if I understand the question, because with non-invasive testing, the whole idea is that the embryo doesn't get manipulated. It just gets grown in culture to the blastocyst stage. And then it gets removed. Yes, it would, at the moment, most of the tests do require that the embryo would have to be vitrified and then transferred back after warming, but there's no further manipulation to the embryo than that. And as we know from several studies, there's a potential advantage to transferring an embryo back in a prepped cryo uterus rather than under the influence of controlled ovarian stimulation. So I'm not sure, I mean, maybe I didn't get the question correct, but that would be my answer with my interpretation of the question.
Thank you. Another question would be, what is the loss rate of PGT-A and of niPGT due to the procedure itself? And what is the overall platform error rate of each? Would one of the genetic counselors like to try that?
It sounds like there's a lot of questions embedded in that, but the loss rate from the procedure from a biopsy is quite low. It does vary clinic to clinic, but the loss rate is thought to be less than 5%, that the embryo doesn't survive a biopsy. So the vast majority of embryos do very well with embryo biopsy, and I don't expect there would be loss rate for non-invasive. I think that, again, would depend on the clinic's protocol. And I think the error rate is another one that we discussed quite a bit. It's difficult to say this is an error of test performance or whether this is a mosaic result or which test is better, PGT-A or non-invasive PGT-A. So it's hard to say what the error is at this time, and that is one of the limitations of the new technology. I don't know if one of the other speakers wants to fill in the blanks for what I might be missing there.
I can say that for the current cases that I presented on, no samples were lost. I've been with our center for a year about, and I am not aware of any sample loss since we have started mainly doing non-invasive PGT-A. We still do some cases of trabeculoderm biopsy, whether it be for single gene cases or if patients have done that in the past and that's what they're comfortable doing with, returning for a future cycle. But I can just speak personally from where I am located.
So I'll just add to that with respect to the Rubio study and the loss of signal, the loss of samples by virtue of failure of amplification or noise. So as I presented, 8% of their specimens from the non-invasive testing were not usable for the analysis. So there's a loss in that respect with the non-invasive testing, which at least in their hands with the 1,300 or so embryos that they assessed was much higher than the loss with respect to the actual analysis from trabeculoderm biopsy, which is the order around 2%. I think it was 2.1 or something percent. So, or 3.1%, I think it was, which is, so it was about double the loss with the non-invasive testing from the analysis itself as opposed to the embryo. I agree that the biopsy procedure itself, if it's done by skilled embryologists, should result in a very, very low loss rate of the embryo. I mean, less than 1% actually. But of course, it depends on which embryos you select for biopsy as well. If you're very aggressive in the type of embryo that you biopsy, you're going to run a greater risk of losing the embryos. They have to be of sufficient quality.
Thank you very much. Another question is, what is the potential of niPGT for detection of segmental aneuploidy?
The resolution of non-invasive is similar to PGT-A with a 10 megabase resolution, so we expect to detect deletions and duplications that are higher than that. In our experience, it is the segmental aneuploidies that are less concordant with the PGT-A results.
Thank you. Ms. Barone, would you like to add on?
Really, I would just echo that in that we do see, per some of my case examples, when we do see those segmental aneuploidies, it may make the results a little more harder to interpret in that it could be noisy signals, it could be just artifact of the test itself. And my first case sort of supported that in that the patient had 2 embryos that were very noisy, but had a lot of segmental aneuploidies that were mosaic. And when those embryos were subsequently biopsied for trophectoderm testing, the results that were supported from that biopsy testing were the aneuploidies that were either full aneuploidies, full monosomies, full trisomies.
Thank you. This question is also for Ms. Barone. Do you believe that the cases that you presented support the data presented by Dr. Snyder, saying that partial abnormalities have low concordance between cell-free DNA and trophectoderm biopsy? After your experience with these cases, do you still not recommend transfer segmental abnormalities based on niPGT-A results?
Very good question. I would say that after, these are 3 cases, very small sample size, I have sort of tailored and spoken with the other clinical members and lab team of how we really can approach these results. When we see these complex abnormalities, particularly the segmental aneuploidies in mosaic form, it really makes us ponder a little harder about how true are the mosaicism that's found in these embryos. So I've definitely kind of tailored and my genetic counseling about these results in my interpretation, and that if a patient doesn't have any other options and all they have are these embryos with very complex segmental aneuploidies, all are mosaic, we would recommend that embryo as a potential transfer and explain to them that this could be artifact, this could be a noisy signal from the chest, and this embryo could be euploid, or there could be mosaicism in this embryo. At the end of the day, we can't predict the outcomes for these embryos in terms of transfer success solely by looking at results on paper. However, when we see these segmental aneuploidies and really nothing else in the results, we may sort of fall back on them as having a little more confidence in them than we did before.
Thank you. And I will do one last question. Thank you for staying on a little extra. And the question is it possible to design a randomized control trial for intention to treat through birth outcome for no genetic testing, PGT-A and niPGT? Where could this study be performed given the current U.S. embryo regulations? I'm going to start with Dr. Rakowski for this one.
So, I mean, as long as the trial was for clinical purposes and not strictly for research, it can be done in the United States. The United States government has a moratorium on any human embryo research. So the trial can be done here if the goal is to recruit patients who are trying to conceive and have babies. So in terms of the design, obviously the power analysis would have to be run to determine the size of the samples that were needed. And then as was done in the most recent Rubio study, the ideal is to recruit several centers to a multi-center trial, because that way you maximize the number of patients that you can recruit in a reasonable period of time to get the numbers that you want to be able to get data that you can actually believe. So I think it's an entirely feasible study that can be designed and done. Obviously, every RCT of this type is extremely expensive. And so iGenomics or any other company is going to really feel that this is something that they want to do in order to get the work done. But I love the idea as a scientist. I mean, that would be a terrific trial to run.
I second what you just said.
Yeah, I do not.
Well, thank you very much to our panelists. Sarah?
Thank you, Jessica. Thank you to our panelists. Thank you to our attendees. And to our attendees, you will receive a survey by email after the session. Your feedback helps us give you the most relevant content. Your inputs are appreciated. This session was recorded and will be available on our website in the near future. Please watch your email for notification about future webinars. For any further questions or comments, please don't hesitate to contact us at webinars@asrm.org. This concludes the webinar.
So with that in mind, what I would like to do over the next 10 minutes or so is, first of all, very briefly review with you the biology of the pre-implantation human embryo and discuss the two most frequent types of chromosome segregation error that occur in human embryos, and then outline implications of these errors for the accuracy of a PGT-A test. We'll then consider developments in PGT-A technologies. We'll discuss evidence for shortcomings with trophectoden and biopsy. We'll consider current findings and limitations with non-invasive PGT-A. And then finally, I want to circle back with you to the biology of the embryo and very briefly consider the potential compensatory mechanisms to correct chromosome segregation errors.